All right, so hopefully you've had a chance to print out your sepsis case study and then spend some time working through it, looking at the data that you have and just kind of trying to figure out what was going on with this particular client, and then also looking at what's taking place as new labs come in. And so this case study, we're going to work through it together, and this is kind of give you practice at the case studies that will be coming up, these unfolding case studies, because it's similar to this, that you'll be giving vital signs, data, some background history, and then you're trying to make determinations what is taking place, and then apply clinically what your decision-making process is going to be. But one of the key things that we're looking at that's probably different than your bedside nursing is we really want to look at the cellular, look at the tissue level to give an understanding what is going on at the physiological cellular level to drive towards these different points. What's happening and what's taking place. So the situation, we had this lady come into the ED. She's had fever, cough, shortness of breath for a few days. And so she comes in and she gets a tentative diagnosis of pneumonia. They take some vital signs. Oh, she also has a history. So she's got a history of diabetes mellitus type 2, of a little bit, let's see, what do we have? We had COPD and then also GERD and then a half a pack a day smoker, which is kind of significant because smoking can cause metaplasias within the bronchioles. And so with metaplasias, you can change out your pseudostratified ciliated columnar epithelium for patches of stratified squamous epithelium. And those are great breeding grounds for bacterial colonization. And so you'll start to see individuals that smoke actually have more lung infections because it's easier to colonize those surfaces. Anyway, so she came in with some generalized weakness and body aches. That's just the general malaise. That's the response of your body's immune system, and it's that chemical signaling that causes that initial kind of just, you don't feel good. Okay, so we're going to look at her vital signs. So her blood pressure is 98/55. Now, we don't have a baseline blood pressure for her, so this is our first contact with her. I would kind of want to know what is her baseline, because some people live at 98/55 and they do great. In fact, if we calculate out her mean arterial pressure, we're good with it, because her mean arterial pressure is 55, which is your diastolic, plus the 1/3 of your pulse pressure. Pulse pressure is systolic minus diastolic. We get 43. We divide that by 3, and then add that back into 55. We get a perfusion pressure of 66 millimeters of mercury pressure. I'm completely happy with that. Excuse me, because we're going to perfuse the brain, the kidneys. We're going to have good tissue perfusion. Okay, so the next thing we look at is heart rate. Heart rate is 108. I'm thinking, well, maybe that's not her normal blood pressure because her heart rate's a little high. So her heart rate might actually be compensating for a drop in blood pressure. Respirations are a tad high, and so 19 would, again, want to know what her normal is. It might be normal because of her COPD. Temperature 38.9. I'm going to do the calculation for that. I take my Celsius, times it by 1.8, add 32, and I get a temperature of 102.2. That's to be expected because she does have the tentative diagnosis of pneumonia. And so we don't know if the pneumonia is bacterial or if it's viral pneumonia, because that pneumonia diagnosis is kind of a catch-all for an infection of the lungs. And so it's likely that IL-1 released by the macrophages is acting as a pyrogen and driving up the hypothalamic thermostat. Her saturation is 92%. It could be because of her history of the COPD that she's retaining CO2. It also could be that she's febrile because, again, your SaO2 is going to go down as your temperature goes up. Now, the first thing I always do when I walk onto the floor is I'm always going to get my Chem 7 and my blood panel. I want to know, get a snapshot of what the patient's going through. So the first thing I do is draw out my Chem 7. And so some of you likely do this too. So you'll get your sodium, your potassium, your chloride ion, your bicarbonate. Now this is your CO2, but the CO2 is actually a measure of bicarbonate. And then of course my BUN, my creatinine, and then my glucose. And then up here we have your platelets, we have your H&H, so your hemoglobin and hematocrit, and this is, of course, your white blood cells. So when we look at this, I always want to kind of notice like what's out of range. And so one of the first thing I note right here is that my white blood cells are high. I would absolutely expect that with pneumonia because white blood cells are actually stored in the trabecular bone or trabecular spongy bone. And so with chemical signaling, the cytokines that release during inflammation, those chemical signals, the colony stimulating factors, the interleukins, will circulate and actually cause the release. And so you have these mature white blood cells diapedesing into the blood and starting to increase our white blood cell count. When I look at the hematocrit and hemoglobin, those are normal, no concerns there. I look at platelets, no concerns there. Those are within the normal range. The same thing with sodium. Sodium is normal. It's 135 to 145. I'm right at the midpoint. Potassium, 3.5 to 5.0. I'm not concerned there. Chloride is normal. I look at my bicarbonate, and I am a little bit concerned about bicarbonate. I'm just going to, right now, I'm just going to note that this is a little bit low because my bicarbonate normally is 22 to 26 milliequivalents per liter, but this one's at 21. So I'm just noting that. And BUN is normally 10 to 20. That's normal. Creatinine is normal. Glucose is high. I'm not too concerned right now because of two reasons. One is she does have a history of diabetes mellitus type 2. The other thing is that she is in she's having a stress response, and cortisol will increase your blood glucose level. This is going to be addressed, probably with some insulin to see if we can bring those levels down. GFR is normal. Lactate I'm concerned about because lactate should be around 2.2. It's slightly up. Now, I'm going to start keeping an eye on something now because now that I know my bicarbonate is down and my lactate is up, I'm going to keep an eye on my anion gap, and then also I want to see what's going to happen with respirations. So I'm going to keep a close eye on this patient. I look at the anion gap, and anion gap, what you do is you take your sodium, and then, so your sodium's over here, and your positive charges are balanced, offset by your negative charges. And so your negative charges are your chloride, and then of course your bicarbonate. And then the gap is what's not made up by the chloride or the bicarbonate. So I have this little gap right here, and this is usually negatively charged proteins within blood. That's offsetting the positive charge, so you maintain that electrical neutrality. All right, so that was our first set of data. I'm gonna keep an eye because of her bicarbonate, her lactate, white blood cells, and she's got a known infection. I'm going to watch the respiration, and also watch the blood pressures. All right, so now we come back, or we keep an eye on her, and we get some new vital signs. And so new vital signs, now I'm concerned because with my vital signs 72 over 36, I do a quick calculation, mean arterial pressure is 48. At this point, she's not getting good perfusion. She's not getting good perfusion to the tissues, to the kidney. I want to make sure, we might have to do something to volumize her. I'm looking at heart rate. Heart rate is up. And so now I think back to the blood pressure, heart rate regulation. So now I know that what's taking place is she doesn't have good volumes. And so I have to ask myself, why aren't her volumes good? Something's taking place. And so the pressure is dropped in the aortic arch. It's decreased the activation of that NTS, which has decreased the activation of that the caudal ventrolateral nuclei, which has decreased the inhibition of the rostral ventrolateral nuclei. And so I'm increasing my heart rate. I'm also allowing the nucleus ambiguous to also withdraw ACH to increase my heart rate. Respiration is coming up. I'm concerned. Now I'm going, okay, what I was kind of wanting to watch for here, I'm now seeing, because now respiration is coming up. Now when it does, again, we ask ourselves, is this primary or is this secondary? What I'm thinking now is this is secondary, because what she's doing is she's breathing rapidly and she's trying to get rid of this. So she's blowing off CO2 plus H2O. So if it was primary, can you see that? No. Okay, so she's got H2O plus the CO2, and so what she's doing is she's trying to get rid of that CO2 plus the H2O. So I don't think that she's breathing rapidly, sending herself into respiratory alkalosis. I think that she's breathing rapidly to compensate for metabolic acidosis. I look at her temperature continues to come up, and then I look at her SaO2. SaO2 is dropping. I kind of expect this because now I'm thinking not only is she more febrile, which is decreasing my SaO2, but she also might be becoming acidic, which is decreasing my SaO2. And there also might still be some infiltrates within the lungs that is causing that to drop even further. I want to see if she responds to oxygen by the nasal cannula to see if there is, the infiltrates are starting to play a role in that. Okay, so then I pull out my panel again. looking at my blood. And so one thing I noticed is that the white blood cell count has increased. I still expect that. And so, but it's telling me that this is pretty aggressive, this infection. And so it's sending out lots of signals to release white blood cells from the trabecular bone. But another thing I noticed is that my H&H has gone up. Now my H&H, red blood cells aren't stored in bone. You have to have hematopoiesis. And with that hematopoiesis, that's going to take about 5 to 6 days to start to see an increase. So something else is going on here. And so one of the things I do is I look at this increasing, and so I think to myself, why did especially the hematocrit increase? Because if I take my blood and centrifuge it, over here her hematocrit was 36%, which means the rest of the percent is in plasma. Now, when I look here, it's actually increased. My thinking isn't that this increased. My thinking is that the plasma decreased, and that plasma decrease bumped this up to 48%. So now my question becomes, where's the plasma going? All right, and then my BUN has also gone up. So what I'm thinking is that I'm hemoconcentrating these values. Now, the other thing I notice is that my platelets are going down. We're going to come back to that and talk about why your platelets might be going down, but that's a concerning sign. Okay, I come down here and I'm looking at my Chem 7. I notice that my sodium's roughly the same. I'm noticing that my potassium has gone down. I kind of expect that potassium to go down because over here we gave her insulin to try to get her glucose down, and insulin stimulates those sodium potassium ATPase pumps and is probably bringing some of the potassium into the cell. I look at my chloride, it doesn't really change, but here's the thing that's most concerning is my bicarbonate. My bicarbonate has gone down quite a bit from 21 to 16. So that confirms that she's probably in a state of metabolic acidosis at this point. And so my question is, where is the bicarbonate disappearing to? The BUN has increased, the creatinine has increased, and I kind of expect that because if I look at my GFR, I come up here, my perfusion pressure has dropped. And so I'm not perfusing the kidneys very well, so my GFR has dropped. And my GFR dropped, I'm going to increase my BUN and also my creatinine. The other thing I notice is that her glucose is really trending up. And so 238, her system is extremely stressed. She's releasing cortisol, it's going to cells, it's activating the proteasomes, they're grinding down the globular proteins, releasing those amino acids into the blood. They're being taken to the hepatocytes for gluconeogenesis, and so my blood glucose is going up. But that doesn't explain everything, because the other thing that's causing it to go up is the active infection. The macrophages are releasing TNF alpha. TNF alpha can actually go to go to the tyrosine diameres and partially block the action of insulin on those tyrosine diameres, so I'm not expressing those GLUT4 proteins, and so it's decreasing the intake into the cells of the blood glucose, and I'm getting persistent hyperglycemia along with that. And then this is concerning. My lactate has gone to 3.2. At this point, we've already called a rapid on this lady. We're getting people in. They're going to go ahead and take her down into the ICU just because of what we've seen so far. Anion gap has gone to 20. And so what we're doing is we're replacing the bicarbonate over here with something else. And so let's look and see what's happening. So when we look at the tissues, here we've got the cell down here. All right, and so what we're doing is we're coming out of the heart up here. We've got the aorta, it's coming down like this, and then coming back up, okay, into the inferior vena cava. All right, and then of course we also have the pulmonary trunk coming off like this, and then coming back around into, coming out of the right ventricle and coming back into the left atrium, and that's going, of course, to the lung to pick up oxygen. Now, normally, under normal circumstances, what's taking place is at these cells, a lot of times what I'm doing is I'm using glucose and breaking down glucose and completely metabolizing it. So my glucose is C6H12O6. Now, if I take, I'm going to make sure I have enough room on the bottom here. If I take C6H12O6 and add 6O2, I'm going to end up getting 6 CO2 plus 6 H2O plus roughly 36 ATP plus heat. Okay. Now I can do this as long as I have oxygen. So hemoglobin is coming around in my red blood cells through the vascular system, and what's happening is oxygen is splitting off the hemoglobin, going into the cell, and now I can take my C6H12. Well, first of all, with glycolysis, I can go C6H12O6 into 2C3H4 O3. And so I got 2 times 3 is 6, 2 times 4 is 8, so I'm missing 2 hydrogen ions here, and then 2 times 3 is 6. Well, those hydrogen ions were actually pulled off, because what's happening in here is I'm taking 2 NAD, and I'm handing 2 of the hydrogen ions to the NAD, and then I'm taking also 2 extra hydrogen ions. So basically, I'm doing this right here, is I'm taking 2 NAD, and I'm kicking it over into 2 NAD with the hydrogen ions plus 2 extra hydrogen ions. Now, that's okay, because as long as I've got oxygen coming into the cell under normal circumstances, I can take this into the citric acid, or into the mitochondria, and in the mitochondria, I'm going to pull off this carbon and this oxygen, and I'm going to make CO2. The other thing I'm going to do is I'm going to take the oxygen off here, take it into the mitochondria. I'm going to take half of an oxygen molecule. I'm going to give it 2 hydrogen ions, and I'm going to make H2O. But the key thing to do that is I need oxygen coming to the tissues in order to do this. All right? Now over here, it seemed to be working okay. But over here, my perfusion pressures had dropped. Since my perfusion pressures have dropped, I'm not getting good oxygenation to the tissues. If I can't get oxygen into the mitochondria, what happens, because of low perfusion pressure, what happens is I stop oxidative metabolism and kick back into glycolysis. Once I kick back into glycolysis, I don't have oxygen available, but I need to continue to make ATP. So what I'm going to do is I'm going to keep this process going, but I'm going to kick it out and make a lactic acid. So my pyruvic acid, I'm going to take the hydrogen ions here and here, and I'm going to hand them back to this pyruvate, and now I'm going to get 2C3H6O3. Now, this is lactic acid, but lactic acid does not stay in the cell. It is going to leave the cell. When it leaves the cell, it's going to do this. It's going to form lactate. And so lactate, what we have is H, C, 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 H, H, and then we have an OH, an H, and then a double here, and then OH. So this molecule right here, I'm going to just draw a line around, a circle around it. So this is my lactic acid. However, when lactic acid goes into the blood, it doesn't stay as lactic acid, it disassociates. And what happens is this, is it produces lactate. It loses the hydrogen ion here, and now I have this plus a liberated hydrogen ion. Well, that liberated hydrogen ion, it needs to be buffered. Let me look at it for a different pin here. No, okay, so this liberated hydrogen ion needs to be buffered, so what I'm going to do is I'm going to take a bicarbonate ion and I'm going to buffer it. Now, let's go back to here. Now remember what we were doing on our pH scales. We were coming like this. We had H2CO3 on this side. We had bicarbonate on this side. I had a 1:20 ratio, so I got 20 over here, all right, and 1 over here. Now look what I'm doing. Normally I was at 24, but on this case, I actually started out at a deficit at 21 milliequivalents. So I'd already been doing this for a little bit. And I know I'd been doing this for a little bit because my lactate was already high. So I was already starting to see this lactate molecule in blood. But now, as my perfusion pressures drop and I decrease the oxygenation of the tissue, I start to produce even more lactate. And as I start to produce more lactate, I lose the hydrogen ion, and now I start removing bicarbonate from this side. And that bicarbonate is being taken off this side in order to go and in order to buffer the hydrogen ion. And so that's giving me my H2CO3. And that's being loaded on this side of the scale. So what's taking place now is my lactate is going up, I'm liberating, or my lactic acid production is going up. I'm liberating that hydrogen ion. I'm unloading this. I'm in full-on metabolic acidosis right now. And we know that because look at my bicarbonate. It's really dropped off and my lactate has gone up. And now what I'm doing is, since I loaded on this side of the scale, I need to get rid of it. So now I'm going to start to go into respiratory. I'm going to start to breathe off extremely fast. So I become extremely tachypnic. And so now you can see my respirations, 28 breaths per minute. I'm trying to blow this off as fast as I'm making it. But there's some problems taking place now because I am in full-on septic shock. So why? So we look back up here at these. My volumes are dropping. Well, one of the things that's taking place now is one of the reasons that I am not getting good perfusion pressures is because the bacterium has actually caused an inflammatory reaction within the vessel. So I've released histamine out here. That histamine has caused endothelial separation, and that endothelial separation is now allowing fluid to leak out. So now the fluid is moving out into the interstitial spaces. That's dropping my pressures, and then what's happening then is I'm responding by not only dropping my perfusion pressures and my blood pressures, but my heart rate is accommodating and starting to come back up. But then the other thing that we looked at in the video on hemostasis and inflammation is this. Usually when you're in septic shock, a lot of times it's related to a gram-negative bacteria. That gram-negative bacteria, what it does is it releases the lipopolysaccharide within the vascular compartment. Once we release the lipopolysaccharide in the vascular compartment, we activate macrophages within that compartment. And so one of the things that we'll see is the macrophage will produce TNF-alpha, and what that does is that activates my neutrophil. So now I have this neutrophil that's activated. When the neutrophil is activated, systemically, they start taking in superoxide free radicals and they start to get ready to undergo the respiratory burst. Some of them aren't going to find a way out. And so what they'll do is they'll actually undergo the burst in here and they'll damage the cells. As they damage the endothelial cells, they expose the subendothelial layer. Now think about the hemostasis video. When I expose the subendothelial layer, I have von Willebrand's factor. It's going to form cross-linking with the glycoprotein 1b on the thrombocyte. That's going to release ADP. ADP is going to activate the arachidonic pathway. I start to release thromboxane A2. That causes the cross-linking of the platelets. So now what I'm doing is I'm starting to form platelets all through here, these thrombuses. And so that activates the intrinsic and extrinsic cascade, and I'm starting to use up my clotting factors. So now I'm going into disseminated intravascular coagulation. So now what's going to take place is these things can actually break off and travel. And as they break off and travel, of course, they're going to get caught, they're going to get trapped in the smaller vessels in the fingers and the toes. So you're starting to get petechiae, purpura, your fingers and toes can start to get gangrenous, necrotic. So if you were a physician and addressing this, if you got called on this rapid, you need to address a lot of things at once. So one is we really have to get antibiotics on board. We've got to get antibiotics on board to start to knock down this bacteria that's in the vascular space, likely in the vascular space that's causing the sepsis. But the other thing is we need to address this right here, our perfusion pressures. Because if we can address our perfusion pressures, get our perfusion back up, then our lactate levels will start to decrease as we start to perfuse these tissues again, and oxygen can go in and start the process of oxidative metabolism to kick us out of glycolysis and the production of lactate. So you're going to bolus your patients, and I'm sure as bedside nurses, every one of you has bolused your patients. You've probably gone to where you're running 2 IV bags at the same time, one on the pump at all the way up turned to 999 milliliters per hour, and then the other one you probably have a blood pressure cuff around it and just pumping that blood pressure cuff to try to put fluids in. Well, the other thing is you have to think about as a primary is not only bolusing them, but also getting some colloidal pressure, because when we activated this systemic inflammatory response, the oncotic pressure of the capillary has actually, a lot of the protein has moved out here. So even though we're bolusing them, some of our oncotic pressures in the interstitial space. So you want to get the bolus on board, but now you also probably want to give albumin or some type of colloidal IV in order to maintain these pressures. Anyway, so I've given you notes on the pathogenesis of septic shock. What this is just looking at is we've got this trend. The patient came in with this set of vitals, and then they transitioned to here. And so what we wanted to do is we wanted to look at these particular things and kind of get a deeper look at what's taking place. Okay, so I promised I was going to come back to platelets. So we come over here and we look at the platelets here, 227. We look at here, 127. Why are our platelets starting to drop? Well, we already answered it. Here are our platelets. We can't, when we take blood and we measure the platelets, they're not in the blood. They're attached to the wall, the endothelial walls. They've already formed the thrombuses, and a lot of them have formed thromboemboli and have traveled to different places. So as you can see, sepsis, you've got to keep it on top of it, because sepsis it's hard to diagnose early on, but it's easy to treat. But once you get to this point, it's easy to diagnose, but at this point it's hard to treat, and a lot of times the mortality rate's gonna start to increase. All right, that's it.